Hi, I'm Breathett K. I'm an Associate Professor of Research at Intermountain Health and a Preventive Cardiology PA. In this video, let's talk about how we treat cardiovascular kidney-metabolic health, or CKM. Based on the screening and risk assessments that we covered earlier, it probably won't surprise you that preventing heart failure means that we need to think more holistically about metabolic health, about blood pressure control, kidney protection, and of course, ASCVD, or atherosclerotic cardiovascular disease treatment. Let's revisit those CKM stages and talk about how we intervene at each one, with lifestyle always being integrated within those treatments. At stage 1, patients have excess or dysfunctional adiposity, and this is our chance to intervene earlier. Lifestyle modification is key. However, if indicated, medications for obesity like GLP-1RA or GLP-1 receptor agonists can be utilized. At stage 2, patients may have one or more conditions that need treatment. For example, hypertriglyceridemia, which we would use maximal statin therapy, we would consider fibrates, or add on eicosapentaenoic acid, which is EPA or omega-3. Then they may have hypertension, and in these patients we would aim for a blood pressure less than 130 and less than 80, using therapies such as ACE inhibitors or ARBs if CKD and albuminuria is present. Or they may have CKD alone, in which case using therapies such as ACEs and ARBs would be helpful if albuminuria is present. However, there are SGLT inhibitors that could be added with or without the presence of diabetes. And lastly, a newer class of medications called non-steroidal mineralocorticoid receptor antagonists, such as NSMRAs, can be added as well. Now, for diabetes, if that's present, we would tailor the treatment to comorbid conditions that are with the diabetes, such as elevated BMI, where GLP-1RAs, a newer class of medications, would be helpful in combination with other anti-diabetic medications. CKD is one of the proposed pillars for diabetic treatment, and you would use ACEs, ARBs, ARNIs, SGLT inhibitors, non-steroidal MRAs, and possibly the GLP-1RAs. Of course, metformin remains foundational in the American Diabetic Association guidelines. Remember, reducing UACR by greater than or equal to 30% can slow CKD progression. In stage 3, patients may have subclinical cardiovascular disease, and subclinical disease may look like coronary artery calcium that's greater than 0, which may prompt you to add statin therapy. Calcium greater than or equal to 100, along with lipid therapy, we would consider adding aspirin, or further lipid-lowering therapies such as PCSK9 inhibitors. And now we have data on GLP-1RAs and eicosapentaenoic acid, depending on other comorbid conditions. Subclinical heart failure with an EF less than or equal to 40% without symptoms, you would use ACEs and ARBs or ARNIs and beta blockers. If they have diabetes and heart failure, you would also add SGLT inhibitors, although these can be used alone when heart failure is present. Within stage 4, then, these are patients who have clinical cardiovascular disease, like heart failure, stroke, coronary artery disease, peripheral arterial disease, maybe even atrial fibrillation. So here we would use those guideline-directed medical therapies for heart failure. They're the 4 pillars of beta blockers, ACEs, ARBs or ARNI, mineralocorticoid receptor antagonists, and SGLT inhibitors. These are therapies that are still relevant across all the earlier stages as well, because CKM is progressive and the pathophysiology overlap. I know this sounds like a lot, but the key takeaway is this: these conditions, they are all connected. And when we treat the whole patient, then we're thinking of cardiovascular, kidney, and metabolic disease, we can make a real difference. In our next video, we'll talk about how these medications and conditions can overlap and how we can work with the patient to find the best treatment option for them. Thank you for watching, and I'll see you at the next video.